Board members, are you ready? Okay, perfect. So, good afternoon, everyone. Today is April 26, 2023, and it is 4:01. And as a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Do we have any board members online? Thank you. So the first item of business is public communication. Members of the public who wish to make comments virtually during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 2:30 p.m. today. Yasina, did anyone register to make comments for the Budget and Finance Committee meeting?
We do not have anybody signed up for public communication for the Budget and Finance Committee meeting.
Thank you. As a point of privilege as a chair of this committee, I would like to I would like to acknowledge today's Admins Day and our much appreciation for all our admins and staff across the Central Health enterprise. So thank you for all you do, much appreciated. There's some chocolate here. Please feel free to grab a piece. Thank you for all you do. And a second item, yes. Really, without you, this meeting wouldn't have been possible. Really, thank you so much. On another note as well, I just want to thank Central Health for acknowledging Eid al-Fitr. They included it on their Facebook and social media forums. Really much appreciated. And this is the only way that we can really build it more of a culture compliant workforce when people understand their patient population and their needs, and especially giving the point that as Muslims we fast for 30 days and how that can impact patients' health and well-being. For us to be aware of that is much appreciated. Thank you so much for that. So moving on to our meeting, I would like to move forward with our agenda items. First item is approve the minutes of the March 29, 2023 Budget and Finance Committee meeting. Do I have a motion?
I move.
Second.
The committee approved the minutes of the March 29th, 2023 meeting of the Budget and Finance Committee.
Thank you, Chair Bell.
Second.
Just a second.
Thank you for the second, Manager Valdez. So we have a motion and a second. All in favor?
Aye.
Any abstentions? Any opposed? None. So item moves. Now moving forward to our next item, agenda number 2, receive updates on the preliminary February 2023 financial statements, including capital projects for Central Health and the Community Care Collaborative. Lisa Owens and Patty Beck will be presenting this evening. Thank you for your
Good afternoon, managers. I'm Patty Becky, the controller, and I'll be presenting the Central Health financial statements. If we'll move ahead to the slide for the assets, the next slide. Thank you. Our current cash position is strong with $584 million in cash. And moving on down to the funds that are restricted for capital acquisition, we have $112 million restricted for capital acquisitions. And in addition, we have a restriction for the LPPF cash and investments of just under $2 million. That's a fiduciary responsibility with an offset in the liabilities. And then we have total capital assets of $130 million with total assets totaling about $1.2 billion. Going to the next page. In our liabilities, our total current liabilities are $26 million. You'll notice in our debt service payable, the short term, we have $1.4 million. In February, late February and early March, we made our annual debt service payment. That's why you'll see that that's gone down, and we'll increase that liability in April. Total liabilities are at just under $390 million. And between the liabilities and the assets, we're at a total of $2 billion with $818 million in total net assets. Going on to the next page for sources and uses. Our total sources are at $290 million year to date, primarily made up of $276 million in property tax revenues. That's 96.3% of the total tax levy for the year, and it is 98% of our budget. In healthcare delivery, the costs were $12 million for the month, with year to date at $77 million, which is 27% of the budget. In our total administrative program, our costs were just under $1 million at $946,000, with $6.5 million in expenditures year to date. Our total uses for the year are at $85 million, and our total excess of sources over uses has resulted in a positive $205 million year to date. Going to page 11, specialty care. One more. Two more, I think. Keep going. One more. Okay. In specialty care, our total spend for the year is right about $5 million. So we spend about 18% of the budget. And that is the end of our financials. Are there any questions about the central health financial statements?
Thank you so much, and also thank you for including the major capital project summary. Thank you.
Sure, I will just hit one highlight on that. Lisa Owens, Deputy CFO. We did add the Cameron Center, and then we added, as you requested when those projects were approved, but also debt financed or anticipated cash reserves. And you'll note that 2 of those projects last month were approved for planned debt financing. So that issue is underway, but we will not have that debt financing until later this summer.
Thank you.
This should be updated every month as part of that.
Thank you. I hope board members have found this document to be helpful and useful. So it's on page 42 in our packet. Thank you for that. Manager Valdez, you had a quick question?
Yes, very quick. Could you just repeat that number that was spent of our budget? How much was spent on specialty care?
We're just under $5 million year to date.
Just under $5 million. What percentage of that is our budget?
It's 27%.
Okay. Do we have an idea as to what they were spent? What I guess diagnosis is. I don't know of another way to say.
Well, we do have the specialties listed on page 11
Okay.
of the slides.
I'll look.
Thank
We
you.
have it listed, thank you.
Yes.
Manager Jones?
Yes, this is an operational question, and it's more maybe for the CEO. Is it possible that we can have these reports, well, let me step back. Is it possible where you could get laptops for each of the board members to use here and here only? And at these meetings that we have the opportunity to scroll through them on the laptop, because the production of all of this paper here is problematic. And I just wonder, is that something the board would, I don't know, maybe it's me even trying to follow you on this is challenging as well. So is that something I would suggest the CEO might want to look into, or board members in support
Thank
of that?
you. Didn't we have tablets?
Oh, did we? Okay, that was.
There were tablets, and I would say there's never no time like the present to go back and maybe restart some things again. So, short answer is yes, sir. There is a way I need to have a conversation with IT and look at the budget to figure out how we do that. But then, we need to make sure we build in training and so forth and so on to make that successful. At times we have actually, I remember early on in my tenure talked about moving away from paper, and there were some members that felt strongly that no, there needed to be paper available as well. So we can have that operational question.
Thank you. I definitely agree with you. I think Dr. Bell and I expressed that in the past, and we even asked not to have printed copies. But we'll definitely consider that. Maybe not for this budget season, for this year. Perhaps something we can consider moving forward. We'll see.
And for those who would like to have them, maybe you could have a few extra copies, but for most board members, I think that we could have the laptop. Anything to work on saving the environment, we're very supportive of.
Definitely with that. Yes.
If I may just
thank you.
add also, I just want to remind the Board of Managers that we're in the middle of a software conversion and acknowledge the finance team, but these reports will also look different in the upcoming months as we switch to our new software. And we hope they will bring more clarity and just be more succinct and it result in less paper if produced and printed. And then also, I think as we close Central Health, I can point out that we did receive the GFOA Budget Award this year. Mike,
Yes.
did you want to say?
Congratulations.
We have special medallions for 2020 and 2021, if you'll notice. They're somewhere lost in the boxes of pandemic mail that came in during these 2 years. Well done.
Thank you.
Well done.
Thank you all. Appreciate it. Perhaps we should consider taking a picture with that. And thank you for all your efforts and hard work. Moving on to the next CCC, please.
Okay. So I'll just provide a few highlights of the CCC financials. Looking at the balance sheet, thank you. The total assets as of the end of February were at $12.9 million with very little liabilities for operations and still deferred revenue of $9 million. And you'll recall that is revenue that was received, and until that DSRIP program is completely finished and any measures are being looked at, those will be relieved as we've had successful audits in the past and we anticipate that in the future. So our total liabilities and net assets also at $12.9 million. And on the next slide, the sources and uses year-to-date actual, which is the second column, I would just highlight our other sources of $141,000 is primarily interest revenue from the bank accounts, and then our uses of funds are in the healthcare delivery program, and those are primarily in the operations, healthcare delivery operations. So sources over uses as of the end of February 2023 are $3.621 million.
Thank you so much. Appreciate it. Thank you, and you're actually right on target with my timer here. I just want to let board members know we have quite a dense agenda this evening and a lot of items that will require a lot of time, so I am going to be timing. So the timer goes off, just know, trying to be mindful, and there's a storm coming as well this evening, so make sure that we all leave and get home safely. Any further questions for any board members on this item? If not, this item is just informational item. There's no action required. So moving on to agenda item number 3, receive and discuss a report of historically underutilized business hub spending performance for fiscal year of 2022. Lisa Owens, Belena Bunch, sorry if I butchered your name, Margaret Castillo will be presenting.
Thank you. I just want to introduce Belena Bunch. You've met before, our procurement director, and our new senior hub analyst. We'll be hearing from Margaret Castillo, and I will turn it over to Belena to kick us off.
Good evening, Board of Managers. I'm Belena Bunch, the Procurement Director for Central Health, and I am excited about this report today to let you know about the FY22 Hub report. Just a reminder that Central Health's procurement policy states that we make a good faith effort to assist certified historically underutilized business vendors and contractors to award them with contracts and subcontracts. And I'm excited about our numbers for FY22, where our hub expenditures were 26.88% of the eligible expenditures. Next slide, please. As a reminder, just to highlight the eligible expenditures, they include heavy construction, building construction, special trade, commodities, professional services, and other services. And then those that don't qualify as eligible are listed in the block below. But I also want to just highlight that healthcare expenditures are not categorized as eligible expenditures. Next slide, please. So when we look at our formal solicitations, as a reminder, the formal solicitations are those that are posted on the Central Health website. We post them on the Texas Comptroller's website, as well as the national platform that we use, which is BidSync. And BidSync allows us to span our reach beyond the Texas borders. And so in FY22, we did 10 formal solicitations. Those formal solicitations allowed us to send out more than 140 emails, notifying 21% of that 140,000 emails, of which 21% of those were hubs or small businesses. In that 21%, 548 RFPs were reviewed, and that represented 46% of hubs and small businesses. 56 proposals were submitted for those 10 formal solicitations, and of that, 12.5% represented hub or small businesses with subcontracting opportunities. The formal solicitation categories included landscaping, professional and consulting services, which also included the CHIF service contracts that were awarded, equipment, goods, which were inclusive of medical and network equipment. 13 contracts were awarded from those 10 solicitations, and 5 of those 13 awards in FY22 were awarded to hub prime vendors, which represents 38.5% of the awards. 2 of those contracts were awarded to prime vendors that had hub subcontractors identified to help participate in the work. I also want to note that 2 solicitations had nonprofit proposals. 1 solicitation was for IT, which was limited. It limits us to hub vendors. And then 1 solicitation was for medical equipment, which doesn't qualify for hub eligible expenses. Next slide, please. When we look at informal solicitations, as a reminder, the informal solicitations are not posted on BidSync. Those are the ones that are usually less than $50,000 in expenditures. We usually go to the co-ops and try to pull as many vendors as we can. And we're only required to do, our purchasing policy requires us to do 3 vendors, 3 quotes, but we always try to include a hub vendor when we're requesting those quotes. And so in FY22, we had 7 informal solicitations. Those produced 213 emails, of which 50% of that, of those 213 were hubs and small businesses. 23 proposals were submitted for those, and 6 proposers were hubs, and that represented 26%. The categories included 2 professional or consulting services under technology and training, and then 5 equipment and goods, which were for hardware and network equipment. All of the solicitations were awarded in FY22, and 2 contracts representing 29% were awarded to hub vendors. Next slide. So now we can look at the numbers. And when we look at our overall numbers, we look at 2 categories. One category being operating expenditures, and the other one being CIP, which is continual capital improvement projects. I always want to say construction in progress, capital improvement projects. Under operating expenditures, our total expenditures was more than $11.6 million, and of that, 39.37% represented hub expenditures. Capital improvement project expenditures were more than $8.6 million, and of that, 10.15% were for hub expenditures. And overall, you'll see $20.2 million in eligible expenditures, and that's where you'll see our 26.88% in hub expenditures. Next slide. The next slide just shows you a trend over the past few years that we've been doing our reports. And as you can see, we're seeing a continuous incline in both overall eligible expenditures and hub expenditures. And I think that is a great point. In both, that the orange bar that you see represents the 26.88% of the blue bar, which is the overall expenditures. Next slide. On this slide, I want to mention, before I go into numbers, that these are the numbers that were available to us by all of our government entities. You'll see that the City of Austin's numbers are really low, but right now for FY22, that's all that they have posted, which are their expenditures, which were under $5,000. We reached out to them a few times to try to see if they can give us updated numbers, and they couldn't. They just, like today, posted FY21, and they're still working on FY22. So I just wanted to mention that these numbers represent the data that's available to us right now. But I also want to say that this is where you can see what Central Health has been doing the work. You know, it shows us alongside of our other government entities that are in our immediate area. And we may be the smallest one, but our percentage shows that we're really putting in the work to try to make sure that our hubs and small businesses are getting a great portion of our dollars. Next slide. The next slide breaks it down into categories, and we've been keeping a trend, a 3-year trend, to show the classifications of hub vendors and how the dollars are broken out and spent amongst them. And you'll be able to see that in most of those categories, they are also getting more dollars. So we spent more dollars on hubs, and our hubs classifications are seeing more dollars. And I also want to point out that this year, or in FY22, we were able to recognize one additional classification that we've never done before, which is disabled veterans. And the only reason why is because everybody who does business with us, we classify them according to how they register. So we had one vendor this year that was registered as a disabled veteran, and we were able to recognize them. Next slide. Also in FY22, Central Health conducted a disparity study under the direction of Colette Holden Associates. And upon her recommendation, she recommended that we implement a formal hub program. And that formal hub program establishes narrowly tailored race and gender-based goals that to be established for specific contracts. And Central Health chose that those specific contracts be construction contracts that were $500,000 and greater. From that recommendation, in FY23, the Board of Managers approved the formal hub program, and then Colette Holden Associates also recommended that we hire hub employees. And so I am excited to introduce Margaret Castillo to you guys, and she's going to tell you some of the great things that she's been doing this year and what to look forward to, as she is our Senior Hub Analyst.
Hello. Good afternoon, everybody. I'm Margaret Castillo. I'm the Senior Hub Analyst here with Central Health. I'm happy to say that I have some previous experience with the City of Austin, both with the City of Austin and the state of Texas, working with their minority programs. So with that said, I began aligning the Central Health's subcontracting program through their current programs, which the City of Austin and the Travis County. With that, I working for the City of Austin when I first started with the minority SMBR. I remember my manager making sure that we understood that we needed to have documentation to have a good program. So the documentation, I created the forms, which are the request HSP plan. The HSP plan is is basically the form that has the goals that are set for each project. The NIGP codes or commodity codes will be listed on this form, and any prime that is part of the solicitation will have to list all their subcontractors that will be working on the project. With that, once a project is awarded, if there's any changes to the HSP plan, we need a request for change form. So I created a request for change form for any changes from beginning to end to any project that lists an HSP plan. The next form I created is a PAR report. And the PAR report is going to collect all the data, all of the subcontractor dollars that will be listed on a monthly basis from the prime that's awarded that contract. And that will help us in reporting all the data for any hub reporting. The next document that I created was a contract closeout form. The contract closeout form will be required to be submitted prior to the last pay app. And that form will list all the subcontract dollars that was submitted for that particular contract in the end, so that I can contact the firms and verify those dollars were paid to them. So I also created the SOPs for the HUB program, along with the desktop processes and procedures. I've been very busy since December creating all these forms. It's been a pleasure so far, and it's been very busy, and I like saying busy. So, we had our first, Central Health had our first formal solicitation in January, where there was an HSP requirement on this solicitation, which was the RZ project. We had 4 firms submit responses, and I'm happy to report that all 4 firms were compliant with our HUB program. We awarded the contract this month. I think it was just a couple of weeks ago. So with that, I will be working very closely with the firm that has been awarded to educate them on the HUB program, the newest HUB program here with Central Health. Also with that, I'll be educating my internal customers, which will be the project managers, procurement team, and anybody else that has questions on the HUB program. Next slide, please. HUB vendor engagement and outreach efforts. Central Health will continue to utilize BidSync and the ESBD, as well as advertising in multimedia outlets such as American Statesman, The Villager, and El Mundo. We send out direct messages or emails with statewide chambers and trade associations, informing them of solicitations, as well as Central Health's website to promote open, formal solicitations. Created a bond or a relationship with the communications team to promote solicitations for any HSP requirements using email and social media. As far as outreach efforts, I will be hosting Meet the Prime events with our certified vendors, or local certified vendors, to meet primes that are going to be part of, or that will possibly submit the proposals on contracts that require an HSP plan. I also have attended my first HUB networking event early this month, and have another one scheduled for next month. Those networking events will help with my outreach events and getting ideas from other entities that basically have HUB expos. I also, on a personal note, I am the secretary for the Texas TAP Association, which I have meetings with them on monthly meetings. Next slide, please. As I mentioned, Missy and myself worked with the communications office to create a notification to our certified firms to these are some examples of the notifications that were sent out to approximately 890 certified firms to participate in the Hancock Center Development virtual opening. And I also sent out to about 45 trade organizations and plan rooms. So we're getting the notifications out to our certified firms, interacting with them, and so that they could possibly, be a part of Central Health solicitations processes. With that, I am excited to be part of Central Health, and I want to turn it over now to Ms. Lisa Owens.
Thank you. So just looking forward, as you can tell, we have a lot going on. We have a lot of construction and real estate projects in the queue, so you can anticipate hearing more about this specific narrowly tailored HUB subcontracting plan program, as well as continuing our good faith effort in everything that we do. So we will continue to report on that. As Margaret mentioned, refining our policies and procedures, mostly our procedures, and how we operate and how we can get the word out. We are working on training both internally and externally. As we develop our hub program, we will not necessarily certify firms, but we're starting to develop tools to tell vendors how they can get certified by the city or by the state if they choose, and really helping educate them on how to do that if they're eligible. And then that's specific community engagement activities. We did a lot of work around Hornsby Bend and Del Valley. We will do that around Colony Park as well as RZ. And as the Hancock project is out there, we're already out there trying to get subcontractors to be aware that if they want to work with prime vendors on these large projects, that there is that opportunity. And lastly, we will be implementing a reporting software tool that is, used by most government entities in this area. We're in the process of procuring that and then starting to use that. It'll be a tool that Margaret can work with the vendors so they can submit their reporting and get us the information that they need, and it'll give us better analysis and data as this lifts up. And with that, we're happy to answer any questions.
Thank you, really appreciate it. Thank you, Margaret, for all the work that you have done. But how long have you been on board?
I started December the 5th.
That's amazing. The amount of work that you have done, and specifically, with outreach.
Yeah.
Really, really much appreciate it. Appreciate all your work, Belena, as well, and Lisa. As we're talking about capital projects, before I forget, I know during our previous meeting, we asked to tour a couple of our facilities just to make sure that we can coordinate it in the future. Just before I forget, I think a few board members expressed interest with touring some of our newest facilities. With that, I'm going to open the floor for any board members. If they have any questions, Manager Valadez.
Bienvenidos, Margaret, and thank you all for the good report. Central Health is expanding its numbers and contracting with hubs, and I greatly appreciate that. But I'm going to ask you again to make sure if you don't have it on your list, that you could reach out to the National Hispanic Contractors Association. They have 150 contractors that are Latinos that do work all over. Texas, Austin, Travis County, the state, and national. So if maybe you could start sending them little bleeps, that would be great. Most of them, I think, have gone through the state training for hubs, but you could add them to your
Yes, ma'am.
address cities. Thank you.
Thank you. Other board members, Manager Jones?
Yes, thank you for the report. This is very informative and helpful. Just two points. One is, when I look at this is sort of disturbing in terms of the African American representation in this. So I have a question in terms of your outreach efforts towards the African American community. How can we improve that so that these numbers will improve over time to be more representative of the population? That's one question. The second thing, I've had the opportunity, I've shared with the CEO, several contractors who've expressed interest but are not familiar with all of our processes. So I guess my question is, what kind of outreach are you doing specifically to these organizations? Or I know you work with the chambers, but other organizations, Austin is a big city, people are coming in and going out, so we have constant changeover. So making sure we get those new ones that come in are aware of what we're trying to do in terms of equity in our community. I would encourage you to do that as well. And then finally, and I think the CEO indicated it, if we could have information and flyers about events that we as board members can share in the community to get out about these efforts. Because it's my vision over the next 3 or 4 years, we're going to have a lot of construction and have a lot of opportunity. I want to make sure everyone has that same awareness of it. So.
I would just say also, if you know businesses, we currently do some outreach to the not just the chambers but the trade associations, and as we've discussed in the past, we've expanded it to San Antonio trade associations and out of the area as well to try to expand our reach to the different minority groups. But also, if you do talk to vendors, because we know you are out in the community, We are now able to provide that one-on-one coaching conversations, which we've always tried to do, but we now have a more robust program now for that, and we can help guide people to that. And with the addition of Margaret on our team, we can get in front of these meetings and attend events. So we will certainly keep you on the distribution for our events, but if there are events, please let us know as we try to build our communication strategy each year. Thank you.
Thank you.
Thank you. So who should we contact, you or Margaret or Paulina? Who should we?
Do we have don't we have a hub email?
There's a hub email address that I have.
So directly to the hub email?
Yes.
So if it's possible, if you can share it with our board members, that'll be
And then
helpful.
there's a second means of contact. They can always go to the Central Health website. There's a link on the Central Health website that says how to do business with Central Health.
Is it easy accessible?
Yeah, it is accessible.
Yes,
Thank you. So,
Surface.
Lee and I had a quick conversation earlier this week with Manager Jones about this. I believe there's an all board email that we can send out. We'll have to resend it every so often because I realize things get buried in people's email inboxes. But think of it as a template that you can utilize to send out to individuals that contact you and say, how can I learn more about not just hub contracting, but also doing business with Central Health in general, as Blaine has mentioned. So we'll get something out to you.
thank you for that. Any other questions from any board members? If not, thank you so much for your time. Appreciate it, and for the work that you're doing. And welcome on board, Margaret. I'm happy to hear all the progress you have made this short period of time. Thank you.
If I may just ask one final question?
Yes,
Where are y'all located? Are you here in this building? Okay.
Thank you. Now moving on to agenda item number 4, discuss and take appropriate action on an amendment to the contract with Maxwell Lock and Ritter for annual audit services. And Mr. Jeff Canoto will be presenting. Welcome.
Thank you. Jeff Canoto, Chief Financial Officer. This item should be a quick item. There was information in the packet, but it is an action item. So the action item is to seek approval and a recommendation to the full board related to a contract amendment with Maxwell Lock and Ritter, who is the Central Health's external auditors, related to some additional tasks around generally accepted accounting principle implementations. And I'll talk a little bit about what those are here in just a second. So the action item is to amend the contract for an additional $16,000. And again, just as a reminder, this is the Central Health external financial audit that we do every year. So these are typical things that happen periodically in the audit process. But just as a reminder, because we have different audits and performance reviews going on, this is associated entirely and solely with Central Health's financial audit. So these are related to that specific contract. And so the three items are really periodically there are some accounting pronouncements that come forward that change the way that Central Health's required to report on its financial statements. You guys have actually seen one of them, which is what's called a GASB. These are standards that are set by the Governmental Accounting Standards Board that requires Central Health to report leases differently than in the past. And so from an auditing and implementation standpoint, there's a lot of work that goes into that particular implementation period. And that's what this is for, related to GASB 87. The other reporting standard that's a part of this is another GASB you'll see next year related around IT and subscriptions for IT services and how those are reported. And it's kind of the same thing. There's just a lot of extensive work that has to be done to track down every IT subscription and make sure that it's reported correctly, not only on both our side, but the auditors will have to undergo additional procedures to test through that implementation piece. And then lastly, the third thing is related to COVID-19 FEMA reimbursements. So Central Health applied for and was eligible for expense reimbursements related to COVID-19. Those reimbursement amounts exceeded what's called a single audit program threshold, and so it invokes what's called a single audit process, which is another part of the financial audit that we typically don't have because we don't have grants that are substantial enough that meet that threshold. But the FEMA portion is related to the single audit threshold, and so it'll be a subsequent reporting part of the audit for the upcoming audit. So all in all, asking for approval for a contract amendment in the amount of $16,000 from the Budget Finance Committee meeting, and then again, a recommendation to the full board for approval.
Thank you.
Thank you.
Thank you
Happy
for
to
that.
answer any questions.
Thanks for clarifying about this item. It's strictly Central Health's audit. Nothing has to do with our external audit with the county. Thanks for that clarification. And this additional funding will come through the budget line on professional development, I believe.
Yeah, consulting services.
Consulting
Right.
services. So, so as you know, members, the ask is just to extend, I think, $16,000 for this.
Right. And the reason we're bringing this, just to clarify, the contract, this particular contract states any contract amendment would come to the board. So remember the external auditors report to the Central Health Board of Managers. And so any contract amendment would come to you guys for consideration. So that's why we're bringing this forward.
Thank you. Are any questions from board members? No. You have a question?
Well, do you need a motion and then we can ask questions under discussion?
Sure. I will entertain a motion.
Okay, then I'll go ahead and make that motion and ask some questions, at least one. I move that the committee recommend that the board amend the Maxwell Lock and Ritter agreement to add additional tasks as reflected in the draft amendment provided to the committee.
Do I have a second? Manager. Yes, Manager Valdez.
Okay, thank you for that, Jeff. So, in looking to, let's say next year or the following year, whatever, upcoming years, what we'll be getting is the professional development so that our staff will be able to update whatever it is that the government regs are allowing for in the future years, and this year and the future years.
So this particular.
Because you said professional development, so is it our staff that's going to be trained?
I actually didn't say that, but.
Oh, I'm sorry, I misunderstood.
But what this does is it provides the funding for additional audit services. But I would say that as part of the process, it's the first time for us as a professional staff to go through this also, so we learn how to report it. And so there's an implementation period. Think of it as the first time you do something, and it's fairly extensive because you have to go and locate all pertinent items to report. But once you do that, you have a process that moves forward in subsequent years. It's not additional cost. It's really just the implementation period, and staff is trained on. Staff becomes familiar with it, knows how to do it. In this case, we've acquired some software to help us accumulate the cost in a way that the auditors are comfortable with. So it's our most efficient way of trying to implement these reporting standards.
Thank you.
I just wanted to ask, just a follow-up then, is to see whether or not there would be, maybe next year, some additional rules or regulations or opportunities that we might be able to take advantage of in the future, that this would benefit us.
Yeah, I don't know if I'd call them opportunities or really requirements.
Yes, sir. Well, to comply with whatever.
But, right,
updated.
and as the, Accounting Standards Board, develop and implement these requirements, we have to follow suit. So it's really more of a process of trying to follow the standards so that we can produce what are called GAAP financials, generally accepted accounting principle standards, and that's part of what the auditors look at in their procedures is, do your financial statements meet generally accepted accounting principles? And that's what this is part of those reporting standards that make up generally accepted accounting principle financial statements.
Thank you, Jeff.
Thank you, board members. Any further questions? So we have a motion by Manager Valdez and a second by Manager Brinson. So we had our discussion, now ready for a vote. All in favor?
Aye.
Any abstentions, everyone? So it seems like it's unanimous. Thank you so much, Jeff. Appreciate it. So we'll move on with our next item. Item number 5, receive and discuss an update regarding Sendera Health Plans, Inc. financials and proposed business strategies. And B, a content overview of the quarterly financial and operational reports for community care, health centers, and Sendera Health Plans. Mike Giesland will begin with public presentation on sub-item B. Then Perla Cavazos and Elizabeth Bernache will be presenting. Mr. Giesland.
Yes, thank you, members. I'll be brief. Members, what you have in your packet under this agenda item 5B, which is the quarterly reports for community care in Sendero. I just wanted to put this in front of you for awareness. You've already looked at. Thank you. You've already, seen this content, but per your instructions, we went back in, we incorporated the feedback from the board that was provided to us, and then also sought input from partners. And so what you see in green italics was provided to us by Sendero, and then blue italics from community care. And so, again, no action needed on this, but we just wanted to get this in front of you. Just as a quick last check-in before we actually, because we're working with the partners right now to bring back the first round of quarterly reports under this content framework.
Thank you.
Happy to answer any questions. This is an important part of an oversight role for this board, too.
Thank you, Mr. Giesland. Do we have any questions about what Mr. Giesland just shared with us? Yes, Manager Valdez?
I'm sorry, I missed the update. I think it was probably at the last meeting when this was discussed. I had to leave early. But I'm just asking whether or not there was a move to look at perhaps consolidating the call centers or the staff for the various enterprise members, which I guess would include Sendero and Community Care and Central Health. And if this is going to take any of that into consideration, since we're dealing with the same demographic, maybe different members or different patients based on the services being provided.
Yes.
But the call center and that activity, maybe even navigation, are all items that could be housed, I would think, in one place, unless there were going to be specifically some people would be housed in the different clinics. How is that?
Yes. So if you look at the last 2 bullet points here, major operations and activities, brief summaries driven by significance profile, et cetera. And then there's a section that was that you currently don't see in quarterly reports, but it's a place for some narrative or some commentary around how work and resources are aligned. And so you've got really 2 opportunities here, but keeping it very broad so that perhaps it is call centers or patient navigation or care management or any number of things we are working together on that can certainly fit under these. And then if it's even an emerging issue that's not quite ready yet, we can certainly bring it up under these.
Thank you.
Thank you.
So with that, I will read item 5A, where we'll receive and discuss an update regarding Sendera Health Plans, Inc. financials and proposed business strategies. I announce that the committee is convening in closed session to discuss agenda item 5A under Texas Government Code 551.085, governing board of certain providers of health care services, and or Texas Government Code 551.071, consultation with attorney. So we'll move into closed session. It is 4:50.
Ready?
Thank you. Well, we are out of closed session. Today is April 26, 2023. And members, please. I've gavelled twice. So, members, today is April 26, 2023. It is 5:54 p.m. We are out of closed session. There are no action necessary for that item. Now we're going to move on to item number 6, confirm the next Budget and Finance Committee meeting date and time, location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, May 24th, 2023 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment.
I move adjournment.
Second.
So I have a motion to accept adjournment and a second from Manager Valadez. All in favor?
Aye.
We are adjourned. Thank you.
Okay, members, we will go right into the executive committee meeting. Good afternoon or evening. Today is April 26, 2023, and it is 5:55 p.m. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. Public communications. We will receive public communication for both the Executive Committee and the Board of Managers meeting before we proceed to the Executive Committee meeting. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via an online form or by telephone no later than 2:30 p.m. today. Yesenia, did anyone register to make comments either at the Executive Committee meeting or the Board of Managers meeting?
Yes, Chair Bell, we have 3 people signed up for public communication for the Board of Managers meeting.
Okay, you can take it from here and read the rules.
Thank you. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for the meeting. The board may choose to set aside any new issues for discussion at a future meeting. We received 3 submissions for public comment. At this time, I will call on our first speaker, who is here with us in person, Jeronimo Rodriguez from Ascension C.
Oh, you can come on up, sir. We were expecting to see you on the videos, so to actually see you in person, it sort of throws us off.
Well, it's nice to see everybody in person. I was told that a lot of my other colleagues were going to be here in person, so I guess I'm here in that capacity.
Great, great to have you.
Yeah, happy to be here. My name is Geronimo Rodriguez. I serve as the Chief Advocacy Officer for Ascension, Texas, and I'm here representing Del Cid Medical Center at the University of Texas at Austin and all of our hospitals here in the community, and we're here in support of the 3.96% rate for the local provider participation fund that allows us to draw down federal dollars for the care of the poor and the vulnerable. Okay.
Thank you, sir.
Good to see y'all in person.
We really
Good to see you,
appreciate it.
Geronimo.
It's good to see you.
Thank you, Jeronimo. At this time, I will call on our second speaker, Jacob Holt from St. David's Healthcare, and he is joining us online.
Hi, can everyone hear me?
Yes, we can. Thank you.
Great, well, thank you. Again, my name is Jacob Holt. I'm an attorney representing St. David's Healthcare, and I'm speaking in support of agenda item 2 from the regular agenda for the Board of Managers meeting, increasing that LPPF assessment rate to 3.96%. First, I just wanted to thank all the Central Health staff for putting this proposal together and to the board of managers for considering it. St. David's position is that this new rate of 3.96% is essential because it would help make sure that the hospitals in our community receive all the payments that they're entitled to receive under state law as part of the UC Insure program. St. David's is strongly in support of this rate, and we're grateful for all of the ways that Central Health keeps working to facilitate this strong safety net of healthcare that we have here in our Austin community. Again, thanks for listening, and St. David's appreciates your consideration of this updated rate.
Thank you, sir, and we appreciate those comments.
Thank you, Mr. Holt. At this time, I will call on our last speaker, Bill Galinsky from Baylor Scott & White.
Good afternoon, and thank you for this opportunity. As Yesenia said, I'm Bill Galinsky. I represent Baylor Scott & White. I'm the Vice President for Government Finance for the system, and I'm here to voice support for item number 2, the amending of the rate to 3.96% on behalf of our hospitals in Pflugerville, Austin Oak Hill, and Lakeway.
Thank you very much. Go ahead.
We too thank the Board of Managers for all their hard work and diligence on this effort.
Thank you very much, sir. We really appreciate your comments.
Thank you, Mr. Galinsky. That concludes our public communication for both the Board of Managers and the Executive Committee meetings.
Thank you, Yesenia. Appreciate it. And again, we appreciate everyone's comments. We will now proceed to the Executive Committee agenda. Agenda item number 1, approve the minutes of the Central Health Executive Committee March 29, 2023 meeting. Manager Valadez?
I move adoption of the minutes of the Central Health Executive Committee meeting of the March 29th, 2023 meeting.
I have a motion by Manager Valadez. I have a second by Manager Musite. If any further discussion, hearing none, all in favor? Aye. Any opposed? Any abstaining? Motion carries. Item number 2, discuss and take appropriate action to approve the appointment of Manager Amit Motwani as the Central Health Representative on the City of Austin Regional Affordability Committee. Managers, previously our representative on this committee was Manager Sherry Greenberg. And Sherry is, of course, no longer on the Central Health Board. We had a number of members who were interested in the position, and they all came to an agreement that Manager Motwani would be an excellent representative for us on this committee. So, unless there are any further comments, Manager Musite.
Thank you. Definitely support Manager Motwani for this position. I just have a comment, if I may. So I think it's fair enough what we're asking for our appointed individuals to come and report back to us. And in the past, we've had other board members represent other committees, and but we never really heard back what's happening. Especially this board member is an appointed amongst us, and they're voicing our voice. It's not their individual voice. So I ask that anyone that we appoint, especially with this appointment, that they report back to us what the meetings were, at least if it's a document or paper, that necessarily has to be a verbal, but any kind of a voting that you have made that may impact Central Health, and for us to be aware of what's happening, because it's a very important committee that involves the city and county, and we want to be aware of what the discussions, how we can support you and support this community as well. So that is my ask, and I hope that if other members are in support of that, we can add it as an addendum, however you want to respect that the appointed individual reports back to us.
Thank you, Manager Musite. What I would like to say is that the committees that is going to oversee appointments are going to look at the duties of appointees. The appointee that we are appointing this evening, that is a board member, will have to follow those guidelines also. And so I don't think that we need to amend the motion at this point in time. I think that we will be able to have a document that is a standard document for all of our appointees to be able to provide us with some feedback with regard to the boards that they are appointed to by us. Manager Valadez.
I just want to congratulate Board Member Matwani on that appointment. You're going to live at City Hall. You got CDC, you got the affordability, and if I'm not mistaken, you're still in Montopolis. So you have a bird's eye view of the greatest needs for neighborhoods that don't have a lot of resources. So that especially for that reason, I would support you 100% in making sure that their voices and our voices for the population that we serve are heard. I mean, so go be loud and be proud.
Thank you, Manager Valadez. Appreciate it. Manager Johns?
I would like to piggyback a little bit off what Manager Sanchez was saying, in the sense that, and I'm supporting your appointment, Manager, but I'm talking bigger. I think that when we appoint members, when we appoint members to these boards, we have to somehow or another have some kind of follow-up and feedback and measurement that they actually did what we asked them to do. Because in a couple of these boards, I don't get a lot of feedback from what's going on, and I'm not sure what is being said there and if it's being followed. So I guess what I'm asking, what the Manager Maswati was asking, was asking, is there any way we can put some measures in to say, yes, they did this, they did this, they did this, they did this, on a routine basis, so that we as a board can be assured of that. I'm not saying we need to put this as part of this discussion, but I bring it forward because I think it's a very critical point.
And I totally agree with you, Manager Jones, and thank you for that comment. You, and I will say this later, but you and Manager Valadez and Manager Musaitif are on the appointments committee. So you will be able to discuss that and put that in place.
Put that in writing.
All right?
So ordered.
Thank you. Okay, do I have, Manager Brinson, I have a motion.
I move that the committee recommend that board approve the appointment of Manager Emmett Matwani as the Central Health Representative on the City of Austin Regional Affordability Committee.
Second.
I have a motion by Manager Brinson. I have a second by Manager Musaitif. Any further comments? Manager Matwani.
I want to thank those of you all who said that you would support my nomination to that committee, and also want to be clear that I hear y'all loudly and clearly and agree. Those of us who are, discussing about continuity and accountability around that discussion. I'm a little nervous about who's on the appointments committee and how exigent y'all are going to be about it, but nonetheless, I think that's all around a good thing. And I just, to directly respond to Manager Valadez, I want you to know that I will do I'll do my best.
Thank you.
Thank you very much. All right, any further discussion? Hearing none, all in favor? Any opposed? Any abstaining? Motion carries. Thank you very much, members. Agenda item number 3, review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and committee meetings. Brianna Yanis will be presenting.
Okay. I will briefly go over the May tentative schedules. I can get this. Oops. Okay, so for strategic planning on May 10th, we will have our regular minutes. Tentatively, an update on fiscal year 2023 service delivery budget priorities, a Central Health fiscal year 22 annual report, and an update on Central Health community outreach efforts. For budget and finance on May 24th, we have minutes, March financials and capital projects update, and a Q2 fiscal and operational updates from CUC and Sendero. For executive committee, we have minutes, tentative schedules, and then discuss research and survey reports in alignment with board responsibilities and level of desired engagement, including but not limited to such reports regarding the monitoring of delivery of care, health outcomes, and other relevant information. And then currently on the board agenda, we have minutes, investments, a fiscal year 23 service delivery, budget priority update, and then budget resolution operational updates. And I will pass it to Mike for additional comments.
Thank you. Members, a couple of things. Again, we present these, and this is with the best information, but then a lot of things get shuffled to different months because we have a lot going on, as you know, and there's other exigencies that compel this. And so, this is our best estimate at this point. And then some things, because, for example, with the outreach efforts, we just recently had an update around community engagement and outreach. We may need to push that one off a little bit, for instance. Lastly, there are some other ongoing as well as developing issues around our work with the county commissioners courts on upcoming workshops, as well as the performance review and the legislative session that we'll bring back to the respective committee or the right committee to provide those informational updates. That's not reflected on here, but as those things start to gel and come into form, we'll certainly bring them back to the appropriate committee. Thank you.
That's all I have.
Thank you very much, Brianna. And Mike, we're also going to have probably a further discussion with regard to our partnerships. We're going to talk a little bit about that tonight, but that's going to be in strategic planning for our May meeting. Okay? Any questions, comments, concerns? Thank you very much. Agenda item number 4, confirm the next regular executive committee meeting date, time, and location. Managers, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, May 24th, 2023 at 4 p.m. or immediately after the Budget and Finance Committee meeting at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. Manager Valadez?
I move that we adjourn.
Manager Brinson?
I second.
I have a motion from Manager Valadez and a second from Manager Brinson. Any further discussion? Hearing none. All in favor? Aye. Any opposed? We are adjourned. Okay, managers, we will go directly into the Board of Managers meeting. Good evening. Today is April the 26th, 2023, and it is 6:12 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of Central Health Board of Managers. The first item of business will be the consent agenda. Consent agenda, C1, approve the minutes of the Central Health Board of Managers March 29th, 2023 meeting. C2, receive and ratify the Central Health investments for March 2023. C3, approve an amendment to a contract with Maxwell Locke and Ritter for annual audit services as recommended by the Budget and Finance Committee. And C4, approve the appointment of Manager Amit Motwani as the Central Health representative on the City of Austin Regional Affordability Committee as recommended by the Executive Committee. Manager Musaiti?
I move that the board approve consent agenda items C1 through C4.
Second.
I have a motion by Manager Musaiti. I have a second by Manager Valadez. Any further discussion? Hearing none, all in favor? Aye. Any opposed? Any abstaining? Motion carries. We will now proceed to the regular agenda, but members, there are 2 items from our posted agenda that we will not be taking up tonight. Those are items 4 and 5, which were item number 4, receive and discuss a briefing regarding the Travis County Healthcare District doing business as Central Health versus Ascension, Texas, FKA, Seton Healthcare Family, cause number D1GN230000398. And agenda item number 5, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District doing business as Central Health and Mike Peaslin, cause number D1GN17005-824 in the 345th District Court of Travis County. Our regular agenda. Members, I believe our usual motion to limit debate has become unnecessary. Instead of a motion, I will follow Manager Musaitif's example and use a timer on the items in the regular agenda. I will inform members that when we're using more than the expected, this will inform members when we are using more than the expected amount of time on that item. I'll try to give at least 5 minutes for comments and questions for each member, and I will ask that once your time is up and you hear the alert, you will either wind down the rest of your comments or ask your follow-up questions offline. I would really appreciate your cooperation with regarding this. Agenda item number 1, announce appointments to the Central Health Board Ad Hoc Appointments Committee and Ad Hoc Succession Committee. Members, you should have a document in your packet that outlines the membership of this committee, of these committees. And I don't know, Brianna, did we correct the succession committee?
It should be in the packet, it should have.
It's in the packet, corrected? Okay, great. Trying to pull it up here. Okay, the Ad Hoc Appointments Committee, Dr. Manuel Martin is chair, Cynthia Valadez, Shannon Jones, and Madame Musaitif are members. The Ad Hoc Succession Committee, Ann Kitchen is chair, Cynthia Brinson, Guadalupe Zamora, and Amit Matwani are members. Any questions, concerns? Hearing none, Manager Musaitif.
And I think this also falls to other committee appointments. We're all welcome to attend, but it's more of a voting criteria, correct?
That is correct.
So these are not closed
All-
meetings to members.
All committees and all committee meetings are open to every member. So if you want to attend any of the meetings, just show up and you will be called upon. It's just that when we vote, it'll only be the committee members that vote. Non-members will not vote. Most of the time, those recommendations are brought back to the full board, and that's when you will have a chance to make your comments and vote in whichever manner you choose. Any additional questions, comments? Okay. Manager Valadez?
Just if you have an expected timeline?
I am going to leave it up to the chairs of those committees to set up meetings and establish goals and timelines. They will work through Brianna in setting them up. Mike may assign a executive staff that will be your sort of liaison. But I will leave it up to you and the members on what's convenient for you. Okay?
Thank you.
Thank you. Okay, agenda item number 2, discuss and take appropriate action on the proposed amended mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2023 under the Local Healthcare Provider Participation Program, LPPF, in Travis County as required by Texas Health and Safety Code, Section 298E, .151. Katie Colburn will be presenting. Hi, Katie.
Hi, good evening, managers. I'm Katie Coburn on the finance team here at Central Health. Here with another LPPF rate amendment for your all's consideration. Our recommended action to the board this evening is to increase the FY23 LPPF payment rate to 3.96% of net patient revenue to fund intergovernmental transfers for providers who serve low-income and Medicaid patients. Specifically through the Comprehensive Hospital Increased Reimbursement Program, or CHIRP, and the Uncompensated Care Pool. So this is information we share every time. Just as a reminder, this fund is used to fund intergovernmental transfers. We assessed a mandatory fee on inpatient hospitals in the county, and we as Central Health are really a fiduciary body that controls these funds as we use them for this sole purpose. Again, you all approved a rate for the year of 1.26% back in October. We are now requesting to increase it to 3.96% for additional payments that are available this year. And as always, we could be coming back. So just so you're aware, this may not be the last time I come to you for FY23, but this is what is the best information we have right now.
That's great.
So then, just as a brief reminder, the facilities that we assess for the mandatory payment rate are inpatient hospitals in Travis County that are not owned and operated by a government. There are 22 facilities that we assess in the county, and those we are bound by both state and federal law to assess on the mandatory fee on those facilities in a uniform and broad-based manner. So all of the hospitals that meet the definition of being eligible are assessed the same percentage of net patient revenue. So if you have more net patient revenue, you pay more, less net patient revenue, you pay less. But those rules are really inflexible, and we can't change them. So I just wanted to make sure, we discussed that last time, but just as a reminder, that's part of this program. So just, this is our requested action for this evening, is to take the annual rate up to 3.96. That brings in about $150 million across for the entire year, for a delta of about $100 million additional funds for additional intergovernmental transfers. And that's it.
Thank you very much. We appreciate that, and thanks for all your hard work in putting all that information together and working with the hospitals. Manager Valadez?
Move that the board
Go ahead.
approve FY23 rate, LPPF, mandatory payment rate, amendment as proposed by Central Health staff. Do I
Okay.
have to say 3.96%?
No.
Okay.
Do I have a second? I have a motion by Manager Valadez. I have a second by Manager Zamora. Any further discussion? Manager Musaiti. I'll get you.
Thank you. Appreciate it. I'm glad that we've heard from the three major hospitals, St. Davis, Ascension CN, and Baylor Scott and White, and they're all in support of that rate. So I'm glad to hear that. Are we missing anyone else?
Well, there are 22 facilities.
Have we heard back? Yeah, I understand. But have we heard back either in support or not in favor of this rate?
No, I have not heard anything.
Did we solicit them?
I informed every hospital that we assess that we were having this meeting this evening, and gave them the opportunity to participate in person, by phone, over Zoom. Our practice is 5 days before every meeting to let people know about the opportunity for public comment.
Thank you.
Thank you very much, Manager Musaiti. Manager Jones?
I just have a quick question. In terms of assessing, is there any incentivization that we can put on hospitals to participate I'm not here tonight too also.
I'm not sure I understand the question. An incentive for,
Yeah, and maybe I'm not familiar with actually the proposal exactly, but is there any way we can get hospitals, for instance, to incentivize or to locate or to develop or to increase services in areas that are not currently served?
I see, through the LPPF process? I don't believe so. This is a financing method based on the facilities that exist today. I think through our other efforts of system building is how we would encourage folks to provide more care to the population we serve.
Okay, thank you.
Thank you, Manager Jones. Manager Martin?
Thank you. I had a question, educational. These funds are collected from the hospital, and who handles the distribution of this money? Where does it go to? Who puts a claim in saying I need blank amount of money for care?
So, in terms of this specific money, we draw the money in, we keep it in a separate account, and then we transfer it to the state as they make calls for intergovernmental transfer funding for specific programs that hospitals who are eligible apply to the state to participate in. So it's the state that determines how the funds are dispersed once they receive the federal match, along with the local funds to make payments to the hospitals through those programs.
Okay. Thank you.
Thank you, Manager Martin. Any further questions, comments, concerns? Hearing none?
I'm sorry.
Oh, I'm sorry. Go ahead.
Who arrives at sort of the budgetary needs, why raise the rate from 1.2 to 3 point whatever now that we're doing? How is that decision arrived at?
Sure. We collaborate with the hospital systems themselves to understand what their needs are in terms of, they know what they're eligible to receive through the programs with the state, and so we work with them to understand what amount of money they need, which we then evaluate and compare to our understanding of what those programs are, what's needed in the community, and we come to a recommendation that we bring to you.
That's a large increase in funding from 1 year.
It is. Particularly the CHIRP program, Comprehensive Hospital Increased Reimbursement Program, it's funded at, I believe, about $5 billion per year across the state. So, and it's based on, it's an increased payment for every Medicaid encounter those eligible hospitals see. And so there are a lot of funds available, and so we want to maximize that with our local dollars to bring those down.
Thank you.
Okay, Manager Kitchen and then Manager Valadez.
Just wanting to make sure I'm remembering correctly how this program works. So basically, from the hospital's perspective, it's in their interest because the more money they pay in is the more money you can match, more money we locally can put up to be matched, which means they get more money back. So that's why it would be in the hospital's interest to raise the rate.
Yes.
Okay.
They want to maximize the amount of federal money available, and this is how.
Yeah, they get more money if they put up more money. Okay, that's what I thought. Thanks.
But it seems like we work with them to make sure that they give us, it's right, it's the right balance. So they can't we can't set a rate without their input because it could be higher than what they can afford to put up.
Correct. And we want to maximize federal funding and no more.
That's correct.
So that's why we work together to bring you all the rate that you all then decide on ultimately.
Manager Valadez?
Yes, and I know when we first got into this discussion with LPPS a couple of years ago, budget sessions ago, one of the concerns that I had was because there are 22 different systems that we operate, that we gather money for, and some of those areas are extreme. There's many people living in extreme poverty that don't have resources, that don't even have the ability or not eligible for existing programs, Medicaid, Medicare, things like that. And I know one of my big concerns was how are we gonna get those hospitals to open their eyeballs and understand that they've got populations out there that are not being served. And if they could do something more, other than deal with them on an emergency room basis, you know, or charity care or whatever, if there was anything that they could do to IGT for different programs, you know, is there anything we could do to help them? And it didn't appear as if that this was a forum or a vehicle for doing that. Am I correct?
You are correct on that as it is now. I think, you know, Mike can correct me, but I feel like Central Health would be happy to partner in proposing other waiver programs or other ways to draw down additional federal funds. That would be a separate process from the administration of the LPPF.
I was talking like Lee County or Fayette County or some of these other counties that are not necessarily Travis yet, and having attended some of the state regional meetings with representatives from those areas, you know, there's huge need, and it doesn't appear as if there's a lot of incentive for them to prepare any programs that would benefit their population. And I just, that's a state issue, and I just don't know what we can do as a population, I mean, as an entity, to try to get the other organizations to shine a light on the disparities that exist out there. But that's unfortunate. I just wanted
Hard
to
with
say
our
that.
county-based funding
Because
system.
it bothers me every time I think about that. But anyway.
Thank you very much, Manager Valadez. Any further questions? Okay, I have a motion on the table. I will call for a vote. All in favor? Any opposed? Any abstaining? Motion carries unanimously. Thank you. Thank you so much, Katie. We appreciate it. Okay, agenda item number 3, receive an update on continued development of the operational and financial sustainability plan for implementation of the Healthcare Equity Plan. Mike Giesland and Monica Crowley will be presenting along with Dr. Abhi Sharma. I don't see him, so maybe he's... Oh, he's on the camera. All right, I didn't look up. And Danielle Srinivasan and Andrew Heiss from Guidehouse. Welcome.
Thank you. Good evening.
Good evening. Mike?
I'll tee this up and then hand it over to Monica. Or should I hand it over to Guy? I'd like to hand it over to Monica, actually. But I wanted to put this in just reflect very briefly in what this means for us as a healthcare district. And tonight you're going to hear about what is the underpinning for over 150 initiatives that are smartly grouped into common buckets so that things can be implemented in a very efficient and a very effective manner. And you're going to get a glimpse at working documents, and not mock-ups, but what they're actually going to look like. That is going to be very informative, for those folks that are going to be implementing these projects. But it's also transparency, is to let the board know and the public know exactly what we know at this point about these projects. And to put some more context around this, what you're going to see tonight, easily, just based on what we know, and Jeff has put this number out there before, but it's easily $200 million just in the first few years as an investment into building out a high-functioning safety net system, healthcare system. And we're still assessing this, but as things start to form, that $200 million can easily get to $500 million investment into improving and filling the gaps in the safety net healthcare system. And this is important because in February of 2022, the Board of Managers of this body adopted the Healthcare Equity Plan, which had nothing less than either significant or moderate gaps in the healthcare system. And so we're coming back to the community and those and the people that we serve and making good on what was said in February of 2022. And so what you see tonight, it's not a set of loose or lofty ideas. It's reality in its solid state. So I want to thank everybody, and especially Monica, for leading the internal efforts to get us to this point. So I'll turn it back over to you. Thank you.
Thank you, Mr. Giesland. Monica Crowley, Central Health. And I did also want to draw your attention to an additional document that Brianna put in the packet, or put with the packet as a separate document today. That is a list that includes a short title of all of the projects that we are looking at, and that tracks with the presentation that Andrew, Avi, and Danielle are going to be giving. So I'm going to pass it off to Andrew right now. Thank you.
Thanks. And I'll actually let Avi go ahead and kick us off.
Perfect. Thank you. Can everybody hear me?
Yes, we can. Thank you.
Okay, perfect. So Danielle and myself, we couldn't be there in person because we are in different places, taking care of some film-related work that we couldn't get out of. But we are excited to be on the phone to walk you through the progress that we've made between the last meeting and this meeting. So if we move to the next slide, there are a couple of things that we want to go over. I don't think we need introductions. We know each other pretty well. For the body of the discussion that we want to focus on today, we want to provide a quick overview of phase 1 of this tranche of work. And within that, we want to focus on 4 things. So we want to provide an update on the progress that we've made thus far, what we've actually done, and what the outputs of that work currently are. We also want to talk about next steps. We are at a very pivotal phase in this engagement, and we are getting to a phase where we are extremely tactical about focusing on things that are necessary and how we actually execute on them versus being in the strategic realm where we talk about what's the right thing to do. We're going from that to the how of what we actually get those things done. And we want to, again, reserve some time towards the end for questions and to go over the next steps. So the next slide provides an overview of the timeline for our engagement. Just to bring everybody up to speed, we started off this work with a previous engagement that focused on creating the equity-based strategic plan for Central Health. Now that plan was the North Star for us. It told us what we need to do in order to meet the needs of the community. Now for this tranche of work, we use that as a guiding post. So based on what we needed to do, now we took that and started thinking about how we actually get those things done. The first thing that we did there was we looked at the different needs that existed within our community, and we started prioritizing them based on scale, distribution, magnitude, and severity. Now, once we had that initial list of needs, we started to think about initiatives or operational activities that needed to be stood up for Central Health to meet those community needs. Now, when we talk about initiatives, it's the actual how of what we do in order to meet those needs. Right now, we are at a point where we have a very strong list of initiatives, and we are putting a lot of thought into adding details to the initiatives. So timelines, capability needs, KPIs. Where we go next is we'll actually start translating those initiatives into operational roadmaps, as well as financial sustainability plans that support the execution of these initiatives. So I want to go through the next couple of slides at a fairly rapid step because we've seen all of those slides and a number of decks already. So if we move to the next slide, that gives us a anchor for what we want to achieve. Now we want to create a high-performing safety net healthcare system, and this system is essentially an ecosystem that requires the orchestration of multiple capabilities, be it primary care, specialty care, hospital care, and these capabilities need to be orchestrated in a way where they are meeting the needs of the community, but are also supported by back-end functions that make the whole process more efficient. So the high-level takeaway here is that multiple capabilities are needed. These capabilities need to fit one another, and we also need the back-end support systems to make these capabilities functional. Next slide, please. So for us to achieve this vision of a high-functioning safety net healthcare system, what we concluded during the first phase of our engagement, which was when we were drafting the strategy, was that we want to focus on 4 key strategic imperatives for us to go after. The first one was access and capacity. There are access-related challenges, and there are a lot of instances where Central Health, along with our partners, don't have the capacity to meet the needs of our community. So access and capacity was number 1. The second was care coordination. So on the previous slide, you saw that this highly functioning system requires the orchestration of multiple capabilities. Now, these capabilities expand on what currently exists, but they also form steps in the care continuum. So right from prevention, primary care, outpatient specialty care, inpatient care, through to post-acute care, there are these different steps, and we need to focus on how we almost handhold our patients and move them from step to step so that they don't fall through the cracks, and they are always engaged in the system so they have the know-how and are empowered to use the system when they need it. The third thing was member engagement. So our population is unique, and we need to make sure that whatever we are doing is tailored to the needs of our patients. And those needs, again, go from how we engage them, how a physician interacts with them, as well as how we stay engaged with them once they leave the point of care. So member engagement was imperative number 3. And number 4 was the idea of creating a system of care. So this essentially meant that for select areas, we were going to develop capacity that would be operated by Central Health, but for certain areas where that did not make sense, we would still rely on partners so that the system worked in a way that increased the capacity, provided access to our patients, as well as maintained the thread of care by focusing on care coordination and member engagement related functions. For us to achieve these 4 strategic imperatives, there were critical elements that are required. And if we go through these, the first one is clinical staff. We need providers. The second is administrative staff. So for providers to do what they have to do, they need back-end support, right from scheduling through to making sure that the incoming calls are being managed in the right way. We need administrative staff to do that. IT and system capabilities are also required because as we think about refining processes, IT tools, systems, as well as platforms need to work in lockstep with those advancements so that we are creating new processes that are efficient, are in line with what industry is seeing in the commercial space as well. Number 4 was data management. So not only do we need data management capabilities to take care of data that is being generated within Central Health's firewalls, but we also need data management capabilities to gather appropriate data from our partner providers and to eventually hold them accountable to the standards that are in their contract. Contracts and agreements follow through on the data management and the responsibilities that we are holding our partners accountable to. So contracts and agreements were another key thing that we need in order to advance the system of care idea. Number 6 was fiscal capacity. So as Mike mentioned, there are around 159 individual projects that are necessary for us to meet the needs of our community. And as you can imagine, each of those projects is associated with significant funding needs, and we need to have appropriate fiscal capacity in order to do that. Now, to juxtapose that on the fact that finance and funding is always a limited resource, we need to be extremely careful about what we prioritize because we're not at a point where we can run all 159 projects. So we have to make trade-offs between where the need is the most and how we want to use our funds in a more efficient way. And right at the end was infrastructure. So physical infrastructure, hardware are things that every healthcare provider system as well as every safety net healthcare system requires. So that's the seventh key enabler that we need in order to move closer to our goal of creating a high functioning safety net provider system. Next slide, please. Now that we know what our goal was and what some of the enablers and strategic imperatives were, the question that we had in front of us was, okay, how do we take the what and translate it to the how? So like I mentioned, we started with the equity-focused service delivery strategic plan, which allowed us to focus on the what we need to do. Now, in order to translate that to the how, we started this process work with thinking through the initiatives which would make up the operational implementation plans. So operational implementation plans would essentially be the how-to for us to stand up the initiatives that are required to meet community needs. Alongside of this, we also need to think about the financial sustainability of these initiatives. So the upfront cost of standing these initiatives up, the maintenance cost of sustaining these initiatives over a long period of time. So for every single initiative, we need to think about the financial sustainability, and the operational implementation plan hence needs to be juxtaposed on the financial sustainability plan so that we are not talking about things that are high in the air. We are actually tying ourselves to tactical initiatives that are executable given our resource needs and the fiscal capacity that we have at hand. So if you move to the next slide, it talks about phase one of this tranche of work. So for phase one, like I mentioned, we started with the strategic plan, the needs that existed in the community. We took that and started to think about the initiatives that were required to meet those needs. And we are at a point where we have grouped some of the projects, the 159 projects, into initiatives so that we can, again, like I mentioned at the outset, go from talking about the abstract idea of projects and translate that to the tactical idea of initiatives, which actually allow us to gauge our capabilities as well as the gaps that exist in our capabilities for us to move the needle and actually execute and stand on these initiatives. Danielle, I'll pass it to you for phase two and onwards.
Thank you, Avi. So in phase two, we're just really excited about the work that is underway today. So what we are doing now is taking all of the work from phase one, so those prioritized community needs, and all of the work really that's been done to date by our teams together, right? This has been work that's been done shoulder to shoulder with the Central Health team to really develop a path forward that really puts us on path to have the most impact. So where we are today is developing these operational roadmaps that will really help us successfully execute on these projects that will address these critical community needs for the patients that are served in Travis County Safety Net system. So what does that mean? So it means designing our capabilities and that action plan for each project and initiative, and then designing the operating models and financial plans to really sustain success and future sustainability going forward. Next slide, please. So under each category, you will see here that we have 16 community needs that span across 5 key areas. So what this does is it really summarizes at a very high level the community needs that had been prioritized and identified through all of the data-driven, very robust and analytics that have been completed to date. So these projects span across primary care, specialty behavioral and dental health, hospital-based and post-acute care, foundational enablers, so what will help to really enable us to function as a high-performing system of care for the safety net, and then social determinants of health and coverage programs. And this is all very consistent with what we presented to you in the past, but really intend today to really show how we've been building on the good work that's been completed to date. Excuse me. Next slide, please. On this slide here, and then on the following slide, what we've done is shown from a graphic standpoint how we've created a manageable set of initiatives by each capability. So when we think about these initiatives, it's across the 5 domains that we previously mentioned, and then each of the projects underneath. So as Abhi had mentioned, with Central Health support and partnership, we've developed a list of over 150 projects that reflect net new work to be completed to drive impact for the safety net community, and also work that's been underway by the Central Health team as they look to drive impact on an ongoing basis. And again, this has followed a very data-driven approach to really assure that we are prioritizing and focusing our efforts and resources in the right areas. Next slide, please. So consistent with the prior slide, again, showing the projects that feed up to the initiatives. And these are the non-clinical initiatives that we have chosen to focus on for this very mission-critical work. Next slide, please. So what we're going to do, we're very excited about the work that's been completed, is we're actually going to have Andrew walk you through and show you the story of how these projects and capability maps come together so that you can see the sequencing and how these plans are really coming to fruition. So Andrew?
Thanks, Danielle. Good evening, everyone. Good to be here with you all. I'm Andrew Heiss. I'm a senior consultant at Guidehouse, and I've been working with Central Health on the operational and financial sustainability planning engagement for the last, 6 or 7 months now? 6 or 7 months. Time flies. So what I'm going to do is walk you through a couple of specific examples of how we took those projects that Danielle and Abhi mentioned, translated them into more succinct and clear initiatives, and how we've taken those initiatives and started to move forward towards operational roadmaps through kind of an intermediate step here, which we're calling target state capability maps. So first, just wanted to touch on how we moved from a set of projects that address each community need into that more succinct group of initiatives that Danielle just went over. We started out with the equity-focused service delivery strategic plan, which was adopted by this board a few months ago, Mike, I think you mentioned, and began to ideate all of the things that Central Health could do within its purview to address those community needs. We ended up with a list close to 160 individual projects, both that are net new and some that are underway, that will solve for those community needs in a comprehensive way. 160 projects is quite an unwieldy number to manage day to day. And so what Guidehouse and Central Health have done is started to group those projects together based on their anticipated timing, their level of interdependency, and the capabilities, skills, and expertise that are going to be required to execute them. So we moved from a set of loosely arranged projects to a catalog of initiatives that, again, are grouped based on dependency, timing, and skills required to implement. Having created that set of initiatives, that much more manageable set that was on the previous few slides that Danielle presented, we started to think through how Central Health could actually operationalize those things. Obviously, timing is a major component of that, as are the resources required to operationalize each initiative. And that is where we're at today, developing capability maps that outline the types of things that are going to be needed to implement each initiative, and gaining an understanding of what gaps exist between Central Health's current capabilities and where they need to be in order for each initiative to be implemented. So in order to kind of succinctly summarize that capability assessment that we undertook, we created documents that categorize, for each initiative, capabilities into 4 domains: personnel, so the people that we need to implement the initiatives; physical, so the actual space, buildings, land, whatever that is required to implement each initiative; systems, so things like, platforms, so things like systems, interfaces, etc., And then lastly, data management capabilities. So ability to ingest and work with large volumes of data and turn that into actionable insight. Within each bucket of capability, we documented and itemized several capabilities there, and then rated Central Health's current level of maturity as either developing, maturing, or established. I think it's important to note here that Central Health's current level on that maturity scale is not necessarily a good or a bad thing, but all this really allows us to do is understand for each initiative how far we have to go to be in a state where we're able to provide that capability or that service consistent with best practice for the safety net community across the country. So there are some areas that we'll see in a moment that are relatively low maturity, so predominantly developing. And all that means is that as we develop the operational roadmaps, we will have to allow for more time, for more resources to develop the types of skills that we need to implement those initiatives. So we're going to walk through two examples now. One is in the community need healthcare for the homeless, and one is in the community need expanded access to specialty care. I'll walk you first through the initiative in question in particular, and then walk you through the target state capability map, which outlines both the capabilities in those 4 domains, as well as our assessment of Central Health's maturity at current state. So to orient you to what's on the screen right now, the top bar is the community need we're discussing, so in this case, healthcare for the homeless. The initiative is connections to housing and wraparound medical services, and this graphic here shows you the individual projects of the 160 that we categorized as part of this initiative, connections to housing and wraparound medical services. As a quick reminder, these these projects were grouped based on their timing, dependency, and capabilities and skills required to execute. They're sequenced over time and based on dependency. So you'll notice the ones in darker blue here are dependencies in other community need areas, most notably on this one, care coordination and social determinants of health. And then the shades of pink here coordinate or correspond to the timing of implementation for this initiative. Hopefully everyone's following. With respect to the actual initiative itself, I would say this initiative contains 2 main components. The first is having the requisite staff to intercept and steer patients experiencing homelessness to the resources available to them in the community for both transitional supportive housing as well as other social determinants of health resources that may be applicable to them. The second component of the initiative is establishing partnerships with community-based organizations that allow Central Health to have insight into where capacity exists in the transitional housing system today so that we can more efficiently place patients that interact with our system into the type of housing environment that will allow them to work on their health, improve their health, and ultimately live happier, healthier lives. With that, I'm going to shift to the actual capability map and talk through that for a moment. So again, as a brief reminder, the reason we developed these capability maps is to understand at a high level the requirements to operationalize the initiative we just discussed, to move from a more abstract understanding of projects and initiatives into tactical things that need to be executed on a certain timeline, and lastly, to gain a better understanding of how the projects and initiatives need to be phased given Central Health's current level of resources. I'm not going to read all of the capabilities listed on the slide here, but at a high level, the types of things we're talking about as capabilities required to implement this initiative are first and foremost the people that are going to be required to interact with unhoused individuals in the community, gain an understanding of what their needs are, both healthcare related and non-healthcare related, and facilitate connections for those individuals to the appropriate resources from a housing perspective, from an SDOH perspective, and from a wraparound medical services perspective. The second major category of capabilities there, again, in the personnel category, are the personnel to build relationships and manage relationships with local community-based organizations that will allow us to better manage and better understand what the capacity to deliver transitional housing, SDOH, and other services is in the community and to effectively and efficiently match the unhoused patients that we're interacting with those services as they exist. The third major category of capability here is the platform and data management capabilities to, in real time and in an efficient way, understand the stock and flow of available housing in the community. So, of course, it's not the most helpful thing in the world if we don't have an understanding of what housing might be available for unhoused patients as we're interacting with them. We really need a real-time understanding of where they can be placed the same day or the next day. And then lastly, and it's worth calling out here that these capabilities are the things required to execute this initiative broadly and not solely the things that Central Health is responsible for. Of course, we're talking about transitional housing and permanent supportive housing. Underneath all of this is the requirement that we have to have a stock of transitional housing in order to best serve the unhoused patients in our community. Again, not something that is Central Health's responsibility to develop, but certainly a capability that is required in order for this initiative to be successful. With that, we're going to advance to expanded access to specialty care. So this initiative, called Direct Clinical Capacity, as you can see on the left side of the screen here, really relates to all of the things that Central Health is going to do to expand capacity for specialty care. From the Equity-Focused Service Delivery Strategic Plan, access to specialty care is one of the highest, if not the highest, area of community need. And so Central Health has undertaken aggressive efforts to expand access to specialty care. So within this initiative, you'll see projects that hopefully are familiar, such as the Rosewood Zaragoza Clinic, the Hancock Clinic, and then many others. So developing a care model, for example, also falls within this bucket, as are kind of the wraparound business office services that are required to operate multi-specialty clinics. One thing I also want to call out in the long-term category here, we're undertaking projects that are going to build our specialty care capacity in a really significant way, which is going to have a profound impact on the community's health at large. As we implement this capacity, as patients seek access and are able to access the services that they need, health status is going to change for individuals in this community. And so we wanted to call out with a few initiatives here that this is an iterative process that we're going to have to continue to reevaluate in the long term what services are needed in which locations. So as we're building Rosewood Zaragoza and Hancock, we need to keep an eye to the long term and continue to think through where the next buildings are going to be, what the next services are going to be, and how Central Health can continue to provide the right level of service for the need in the community. With that, the capabilities we call out for specialty care predominantly fall in a couple of categories again. So within personnel, we wanted to call out the need for, first and foremost, providers, so clinicians, both physicians as well as APPs, nurses, and other support staff in the clinical arena, business and front office support staff, so folks that are going to actually manage the administrative portions of each clinic, and then lastly, a span of control here, so people like clinic managers, service line directors that are going to kind of form the infrastructure that allow these clinics to function and manage, or to function in an efficient way. Second, obviously, physical space is going to be required here, and so we've called out several areas of physical capacity, both clinical space, flexible and administrative space, and then equipment that are going to be required. It's worth noting with both of these that the staffing model and the clinical space requirements vary drastically by specialty, and so we have chosen to leave these capabilities relatively high level to serve as strategic guideposts that Central Health can kind of shoot for, with the understanding that as we continue down this process, we will need to develop much more detailed understandings of staffing model and spacing needs for each specialty that are going to be within these clinics. Continuing across the slide here, from a platform perspective, an electronic medical record is the easiest example here of a platform that's going to be required in order to deliver multi-specialty care. But we also wanted to call out credentialing as an important function here, as Central Health directly provides healthcare services. An ability to manage a network of providers and credential them appropriately is going to be vital. as is integrated resource planning and financial management systems. And lastly, as Central Health moves into the direct clinical practice arena, ensuring that clinics are performing and delivering on their promise to improve access for the community is vital. And so an ability to manage, ingest, and accurately report on performance management data is of vital importance to ensuring the successful and iterative development of these initiatives. With that, I'm going to pass it back to Danielle to close our portion of the meeting. Thank you all.
Thank you, Andrew. So with the examples that you just saw, we're actually building out similar across all of the major selected initiatives, so 13 in total. And those initiatives address the 5 domains that we visited earlier in this presentation, specifically primary care, specialty behavioral health and dental care, hospital-based and post-acute care, the foundational enablers to really assure a high-performing safety net healthcare delivery system, and then social determinants of health and coverage programs. So really the intent of showing you those examples was the very detailed approach and the thought that has been taken into consideration to really assure that we're positioning for success as we move forward, building this high-performing safety net delivery system across Travis County. Next slide, please. So as you can see, we're working in parallel with work underway for phases 2 and 3, and really at a very pivotal point in this project. So in terms of next steps, it's finalizing the target capability architecture maps to include that ideal state as we think about our future vision and what we're designing for the safety net across Travis County and the capabilities that we required to successfully operationalize these initiatives. We're doing a deep understanding and assessment of the key considerations that we must really understand to operationalize these initiatives. So that includes capacity, post-acute care, and IT needs. And then continuing to develop these operational roadmaps that includes the appropriate staging, sequencing, and timing for execution. And then last but not least, constructing the financial models and to really understand the sustainability and the resources that will be required for execution and ongoing operations. That brings us to the end of our presentation, and I'd like to hand it over to Monica.
Thank you so much, folks from Guidehouse. I just wanted to let the board know, as part of these next steps, as we shared the initiative catalog with you tonight with all of the initiatives on it, we really wanted to start with the examples of the capabilities maps that we shared tonight, because one is an example of a capabilities map that is heavily dependent on collaboration and partners, particularly the one with working with the folks on that housing support services that Central Health is going to be providing the kind of navigation to those services, and also helping ensure that there's access to medical care for people when they are in those services, although we won't be providing the direct social services or housing. So that's a heavily collaborative initiative that we'll be building out. There are also the direct service, the direct clinical service initiative is one that is heavy on Central Health actually building up the direct capacity to provide. As we finalize the roadmaps that, or not the roadmap, the capacity maps for the other 11 initiatives that Danielle was just talking about, we'll bring those back to you to review as well. We also are working with Ted's team. There has been a community conversation around this work already a couple of months ago. going back to the community on the, and the voice of people who participated in the Voice of the Community exercise, with an update on where we are in the healthcare equity plan, additional community conversation so that we are continuing receiving feedback and following up with past participants and accepting, of course, additional participation from community members is planned. And then we will be coming back to you at the June 14th board meeting with additional work on these roadmaps and on the financial sustainability plan.
Thank you so much, Monica. Thank you, House and your entire team. Excellent work. A lot of detail, which we will digest over time. But we thank you a lot because it takes a lot of work to be able to get this done and done right. So we appreciate the fact that you guys have been so diligent and so focused on helping us to get this right. So thank you. Now, members, I am going to give us 30 minutes so that we can sort of go around the room and ask questions. If after that we feel that we need another session, I'll bring it back as an agenda item for another meeting so that we can have a second go at it. So I'll start on this side this time. Dr. Martin, are you ready, or do you want me to? No. Okay, well, let me just skip you and go to Manager Jones.
Thank you very much for the work you've done here. This is like the universe being developed and helping us to understand this in the micro components of it. So I'd like to sort of cut to the chase somewhat is within what we're currently doing, are we going to inculcate some of the services that we currently have and some of these strategies that you've outlined here? I bring that to specifically, I think each manager was provided a copy of a letter that came in from around the Black Men's Health Clinic, which focuses in on making sure services are provided to populations that have been disproportionately impacted. And not only services, but some of the wraparound things that you've talked about as well. So I guess my question is, as you look at building the big picture, are you also looking at inculcating what we're currently doing and some of the other things, obviously, that we're currently doing to make that as part of the big picture as well?
Yes, absolutely. I can take a stab at answering that and then defer to Danielle and Avi as well. But yes, so of the 160 projects that we mentioned, many of those are things that are kind of already in the works with Central Health. And so we've taken an approach to catalog in your words, the entire universe of things that Central Health both already is doing and should be doing to better serve the community.
And Monica, as we look at that, particularly a specific program such as this one, we should, as we go towards the budget period time, we look at how do we build upon what we currently have and or remove things that are not working, but to be consistent with the plan that we're developing here. Is that sort of the strategy that we're expecting?
Absolutely, and one of the things that we're working on with Guidehouse is capturing, this one of the big buckets of work, or I think the initiatives, is this expanded primary care access, which includes looking at the work that's already underway, and that of course you guys are keeping us focused like laser beams on in Hornsby Bend and Del Valley and Colony Park and these other opportunities that we're working on with community care and to continue to expand access to primary care.
Okay, because one of the things I would be looking for as we go forward is addressing the big picture, but also from a public health perspective, how are we improving the mortality and morbidity rates in those communities as well? And not just we're doing stuff, but we are measuring the outcomes of them as well. So I just want to emphasize that. So thanks very much.
And just for the timing of this, we are going to be developing key performance indicators working with Guidehouse. We're working on getting the prioritization roadmap in place by this June-July timeframe so that we can plug it into the budget priorities for next year. And then we're going to continue working on developing the outcome measures and key performance indicators for these projects in the August, September, October timeframe.
Okay, well, I just
Absolutely.
want to emphasize, because I think as outlined here are some of the examples of the way that is being done with the Black Men's Health Clinic, but there are other initiatives underway that we should talk to as well. But I thought that was very informative. That's all I had, Chair.
Thank you, Manager Jones. Mr. Geisler.
And then in response to Manager Jones, we also have things that we're not talking about here tonight, like our demographic report, where we come back and answer those larger questions. Hey, what's happening with a particular health disparity in a community, and then the things that are causing disproportionate impact and mortality rates. So those report, I realize it's up to this body to continue, not my say, but those types of reporting, also get to that point.
But we want to tie them together, though.
That's right.
Yes.
What we're doing and the outcomes of what we're doing.
And those KPIs will be linked with what Monica just mentioned. Thank you.
Thank you very much. Manager Zamora.
No questions, just great work.
Thank you, Manager Zamora. Manager Valadez.
What I'm interested in, and this is a lot of information for us to look at, but it's exactly what's necessary in order for us to lay the foundational pieces of overhauling the system this dysfunctional system that was created. And what we're trying to do is fix it so that it best addresses the needs of our targeted population, which is not public health, it's indigent care. Okay, and those living under 200% FPL. I want to make sure we remain laser focused on that, and looking at our demographic report and tying that together to the needs of the community, the medical needs of the community, based on what the information is that the data is telling us. And in that light, I'd like to also know what we're doing to work with our partners, the other governmental agencies, the county and the city that are responsible for housing. We're not. They are. So what are they doing? What are they bringing to the table for us to be able to address and navigate their system to make sure that our patients are taken care of in their system? And I want to make sure we understand that, okay? We're not reinventing a wheel. We're going to try and put all the pieces together in this puzzle that is going to take care holistically of our patients, our targeted patients for our population. And so, where are we there? Okay? I want to know what the city is going to contribute to this as a partner. I want to know what the county is going to contribute to this as a partner. We're already looking at the diversion centers that are being created right now. How are we going to tie that in to mental and behavioral health? And tie that with integral care, which we're also funding. It's not only primary care or specialty care, but it's mental and behavioral health. It's opioid abuse, blah, 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 all of it. But there are other agencies that are better suited to address those needs. And we are, and have millions and millions and millions of dollars. We're not going to duplicate those services, I hope. And so that's going to be one of the focuses I would think of, is making sure we're not duplicating those same services, but rather we're identifying them. And these are the agreements that we're already working on to make sure that those pieces are taken care of. That's, when I look at the big picture, I remember once we had Travis County on the map. Where are the clinics? Where is our demographic population? The maps are gone. But I like the overlays because they told you a lot as to who was getting served and where they were getting services. And it wasn't where they needed to be. So I'm glad that map is now gone. But this is what we're trying to address with a true equity plan. And so that's what I'm interested in seeing also. And I can hear the beginnings of that, but I don't see the foundational commitments and conversations that are agreements maybe that we need to get from those partners that we're going to be working with to establish those foundational pieces to address the holistic care and quality of life for our patients.
Okay.
And
Mr.
response
Giesler.
to
Yes.
Manager Valdez, and Monica, I'll ask you to comment on this as well, but I'll tee up the first part of the response. If you look at what is page 70 of your books, but the guidehouse slide number, I believe, is 16, and the title of it is Healthcare for the Homeless. If you notice the way that the color coding works on this, you've got established, maturing, and then developing standards. And it's noted here under physical and then under platforms, and I'll just sum it up by saying, is identifying what that housing, where that's going to be. And yes, it is dependent upon partners that are statutorily or perhaps either obligated or permitted to fund those types of things, to doing that. Now, that is a risk that we have. We could put together the best in-class apparatus that anybody has ever seen to be able to connect people to housing and other services that do not involve health care. But at the end of the day, yes, there is that partnership commitment. And I think that's, I don't know that through this exercise, we're always going, and we can tease out a lot of that through this planning exercise over the next several years. And again, I'm speaking for a future that doesn't involve me, but I also think that there's a process by which we can take this work, go to the city council, go to the county commissioners, go to whomever is statutorily obligated and or permitted to do these things, and say, we have this plan right here. And I think, if I could jump forward and say, I think we're going to be able to articulate to a much finer degree, this is what is going to be necessary in order for you to provide what's on the other side of this equation, which is, in this specific concrete example, connections to housing. And so I think those conversations will be a lot more informed with this structure here that's been put together. But at the end of the day, it's going to boil down to those jurisdictions and their governing bodies deciding, yes, we want to match what Central Health is doing, and we want to make these investments to be able to make this a reality as opposed to, something that's less than optimal. So I don't know if that's a fair characterization of the power of these planning documents, but Monica, I'd ask you to chime in and or correct me if I'm reading this wrong. I don't want to mislead the board.
Manager Valadez, may I just, or you go ahead and then
I just wanted to follow up with Mr. Giesland, and I appreciate him saying all that. But it's been since 2015 when I came on this board that I asked Central Health to begin participating with the city and the county and the school district and the ACC, the higher education and UT, in having those monthly meetings and participating in the monthly meetings. And I don't think we've begun to do it. We've done it yet, but it doesn't make a difference. It's never too late to start. And either way, as true governmental entities, we've got to share those conversations and share the planning processes and the burdens, which are the costs, the financial sustainability, as we look at implementing these model changes for a dysfunctional system that was not only created here at Central Health, but in other areas. And so, when the county's putting together a housing plan and they stop building affordable housing, or the city, the same thing. I mean, that's being corrected, but this is what if we're really serious about looking at the holistic approach to dealing with the care of our patient and improving their quality of life, there's got to be a starting point, and I thought that this is what we were doing at Central Health. And yes, they can participate or they can't, but I want to make sure that our public knows that we're doing everything that we can do as Central Health and as a board of managers to provide the opportunities and provide the plans. This is the piece that we need to have. But we need you all who are also public citizens that vote and pay into those jurisdictions, that we need to make sure that our tax dollars are going to provide for the needs of our population. And in there, it's the big P population. It is public health. But for us, the component is laser focused on our targeted population. And I just wanted to make sure that there wasn't a misunderstanding about that.
Thank you, Manager Valadez. Monica?
And just as a follow-up to, to the point you're making, Manager Valadez, so, thank you for continuing to advocate for this focus on our target population and in support of these collaborations. What Mr. Giesland was describing, I believe, is already starting to happen now that you, as a Board of Managers, has approved Central Health really putting a stake in the ground, not just around the direct specialty care, but around respite care and these other direct services that are very aligned with the housing and healthcare for people experiencing homelessness. We have had folks reach out to us from the City of Austin and HACA to have us participate in the Housing Action Plan and in next steps for how some of the voucher programs are developed, and particularly working with some of the populations that Central Health is really focused on, like this low-income, unhoused population that is in need of respite services. And we've, had folks reach out to us from the county as they're developing that Travis County Housing Coalition services about how we could work with them around providing these medical services. So I know it's a long time in coming, and now that you guys have positioned Central Health as kind of a direct participant and provider in these convener, and direct care provider, people are reaching out to us.
Well,
So,
I just want to tell you thank you. I'm very glad we're moving forward.
Okay, thank you. Manager Musaiti.
Thank you, appreciate it. There's a lot of information that needs to be cleared out, absorbed. I want to point out to the board members, I'm not sure if anyone have heard about this recent study that was really mind-boggling, and as we are as a organization trying to address the inequities amongst our population. So a recent study that was just published on April 14th titled Black Representation in the Primary Care Physician Workforce in Association with Population Life Expectancy and Mortality Rates in the U.S. I'm not sure if anyone has heard about this study, but what the interesting finding of this, that Black residents in counties with more Black physicians, whether or not they actually see these doctors, had lower mortality from all causes, and showed that these counties had lower disparities in mortality rates between Black and white residents. And the findings of longer life expectancy persisted even in counties with a single Black physician. So as we're looking at our workforce and as our providers, we need to be very mindful of the diversity of our providers. And given the significance of this study, I think it was representative of almost 2,000 counties, which is quite a very powerful study that I want us as Central Health to really focus on the diversity of our clinicians and our providers who are providing these care, and to really, that's a way that we can close the gap for this specific population. So that is really noted. I just wanted to bring forth, and I highly recommend people to look into this paper that has really been, I've been thinking about it lately the past week since it got published. So thank you.
Thank you, Manager Musaiti. Manager Prince.
First, I want to tell you that I think that you're doing a remarkable job, and I feel very well versed in what you're doing from our previous meetings, and I'm very excited and feel very proud to be a part of it, because we've gotten to hear the clinics that are coming up, we've gotten to hear about the respite care, about the sort of rapid growth of that, and I feel that you have guided us to make the correct decisions, and we bought the right property that will help this initiative really come together. So I'm very proud, and I think it's very clear to me, at least, where we're going and how we're going to get there. So I just wanted to add that.
Thank you, Manager Brunson. Manager Motwani.
This is, obviously really good work. It's excruciatingly meticulous, and that's obviously what's needed. I don't think it's a surprise that that's the product of Guidehouse, and I think that being said, it underscores what I believe, and I think what all of us believe, has been superb vision and management on the part of staff here, from Mike and his executive team, and Monica and John Morgan and respective teams, and many others whom I can't even name. It's about shepherding this process and going back and forth. So all of this excruciating detailery is vetted and reviewed and ping-ponged back and forth with staff. And I don't remember if it was Dr. Sharma or sir, I don't recall your name.
Andrew.
Or Andrew, who mentioned, just as access changes, so then will outcomes, and so then will the needs assessment. And so it just kind of dawned on me with all of this excruciating detail. We have like a waterfall of like cascading contingencies that need continuous data and feedback. Which of course underscores the importance of the capacity all around with the tech stuff. And when you just look at this gargantuan constellation of items, it's so important that we have a product like this. And I want to thank staff and management for guiding the creation of such a product, because then when we allude to other things we've talked about today, particularly, the Regional Affordability Committee, which I think might be a closer iteration of how we may be able to build organic connective tissue around local stakeholders and authorities on shared solutions. I mean, uniquely home available affordable housing or available resources for persons experiencing homelessness that go hand in hand with health outcomes. And so this product is a backbone for so many of these efforts. Not to mention, of course, business continuity and succession, which Chair Kitchen of that committee will surely appreciate, I'm sure, and the whole committee will, having this as a backbone and guidepost, and an incoming executive lead, I believe, would certainly appreciate something like this. So just thanks.
Thank you, Manager Motwani. Manager Kitchen?
Yes, I also want to say thank you. I appreciate the detail, and I appreciate the continued updates. It really helps us, stay on top of it and also follow along as you are developing the different projects and aspects of it. And so I would echo what everyone has said. I have a request that, I can write it down also, but let me kind of explain it. I think, so I'm putting my board hat on, and as a board member, when it comes time for budget, I feel that I need to understand enough about these projects and how I'll call them initiatives, these initiatives and how they're prioritized, so that I can say yes. I mean, I feel like I can say yes now, but I need that. So I would love to see a spreadsheet, which you've got the pieces here, but I would love to see a spreadsheet that tells me the initiative, what is the priority level of it, where is it in the budget, either this one or a future budget, what results are we looking for? Now, I understand you don't have KPIs yet, and that's okay, but you can still articulate what the results are, even if you don't yet have the KPI identified. But I want to know what we're trying to do with it. Then I want to know how it fits the need. Then I want to know if it's innovative or not. In other words, is it a best practice? Some of these things will be cutting edge. Some of them won't, just because of where we are in our development process. but I would like to know if we consider them cutting edge or innovative, or if that's something in the future. And if I can, and also then the last thing is, what's the policy decision? Because now some of these initiatives this board's already made policy decisions around. But some of them maybe not. Some of them maybe the policy decision is just how far to go with it. And I would like that identified for us, and there may not be a policy decision about every initiative. Let me give you an example. SDOH has inherent policy decisions in it. And this board's already made a lot of those decisions, and this group has already made a lot of those decisions. But the conversation we just had earlier, about we don't pay for housing, that's a policy decision. And now's not the time to debate that. I agree with a lot of what was said. I also struggle with that because I know that means some people will fall off a cliff. So I just think that, so I'm not asking to revisit that. I'm just saying identify for us. Because inherent in this process is decisions at every step of the way. You guys have made decisions about priorities. You guys have also made decisions about what initiatives meet needs. Thank you for that. I really, really appreciate that. But as a board member, I need to understand where are we? Is there something we should know as a board and say, yes, we absolutely agree with that? Or where's our opportunity to say, maybe we want to push the envelope a little bit more? Or maybe we want to push the envelope in 3 or 4 years. Maybe this is great where we're at right now. But I would like y'all's help in sussing that out. Does that make sense, that list of things that, you've got a lot of the pieces here. And this is a great list of initiatives, and you've connected it to needs. And then you've got this way of organizing, which is great. So you've got the pieces of a lot of this. A few things I'm not sure we've talked about, and some of that's the policy, some of it's the best practices or innovation. Does that seem like a doable ask, and does it make sense why I'm asking it?
Mr. Giesler?
Yes, it does, and I think, just a couple of things, and mentally I've made a list of the things that you mentioned. My sense is, and I'll defer to Monica and the Guidehouse team on this, is that is absolutely part of the package, if you will, that we bring to the board for consideration, all of those things. Mm-hmm. Now, I will, qualify on the budget. I don't know that the various initiatives, or even the buckets of initiatives where there's a common denominator, are going to have a specified project budget.
Okay.
And so it could be there are elements within the budget that combine together result in this. And so it may be in technology and in the nephrology, specialty care line, and then 3 or 4 other lines. And so, we'll have to talk about what's a manageable crosswalk that we can put together, but also makes sense to you. And that's part of financial transparency too.
Yeah, and I don't mean exact cost for each initiative. I just want to know, where do I find this initiative in our budget? And do we find it in this year's budget, or do we look at it in a future budget?
Where's it coming from? Right.
Is it in this bucket? That's kind of where I'm.
So we may need to take some poetic license, if you will,
sure,
around that.
That's okay.
Absent a true independent project budget for a specific initiative. And then the second final comment that I'll make is, in response to your question, is on the prioritization. And understand that the Guidehouse team and the scores of Central Health people got together, and there's that matrix that was discussed, I believe, at the last strategic planning. So you've got level of effort or resource input, and then the impact, and then you have those quadrants. It is a prerogative of the board. Now, that's just taking what is a level of effort. It's a double axis. You've got those 2 axes that you look at, and you prioritize these things, and then that's where the initiative shook out using that matrix, mm-hmm, or that prioritization scale. Now, it is a prerogative of the board to say, there's something on this list right here that, as a matter of policy, we want to bump up. Mm-hmm. And you can do that as a board. I mean, that's what y'all do. Mm-hmm. What you should do. But it's also coming upon us, with Guidehouse to come back and say, okay, you can do that, but here's what that means in the reordering of things. Mm-hmm. And understanding, if if there's a downside to it, or maybe there's a better upside to it even. You know, we don't want to leave that out, but certainly, you know, I want to make it clear, you know, because you said, you know, you all have decided the priorities. We presented a set of priorities based off of a measurement scale, but ultimately that's the priority.
I didn't mean that as a negative. I meant it as just as part of the process.
Right.
And you also shared with us the matrix, which I thought was very well thought out and made sense to me, you know, in terms of how you would go about prioritizing. I wouldn't do that any different. But if I am thinking that for other reasons that something in this priority should go up here, I don't know that I have the information to even
Understood.
know that.
Right.
So that's what I'm, so.
We got to bring that back.
And I don't know if Andrew or Avi or Danielle is the best one to describe what's coming, because we haven't done it yet.
Sure.
But there's, in addition to it, so, but part of the next few weeks, what we'll be working on in the engagement is setting up as part of this overarching timeline or roadmap with all of the initiatives that places them within a timeline. So there's, you know, kind of the quadrant that was the initial prioritization thought process. And then there's another deliverable that we will be bringing back to you for feedback with additional information like the gaps and capabilities, an ideal state assessment that Danielle discussed earlier, that will include, and so I think in addition to what you're asking for, which I think is absolutely reasonable, there's another kind of deliverable that we'll be bringing back to you guys for discussion, input, and you know, kind of instruction on, and you know, is that it kind of a next prioritization.
Okay.
That is prioritization in terms of the timing of taking things on.
Well, this is great detail. I want all the detail. I'll be digging into it. I really appreciate that. It's just for me anyway, and others may think about things differently, but that's how I can organize it in my mind and think about it with my board member hat on. So, oops, time's up.
Time's up.
Thank you.
But you get 5 minutes.
It'll take a lot less than that. I would like a little more detail. For example, y'all listed, you know, as we all recognize, an enormous need out there. So there's an enormous capacity that has to be met. And just briefly looking through these things, you notice, for example, what physician visits per day at the specialty clinic is 12 to 16. I'm curious how you all arrive at that number, and if you think at that level, that kind of minutia, how do we arrive at that staffing model for outreach programs, for clinics in particular? I mean, I can't think of a private practice in Austin that sees 12 patients a day. And granted, these are more complicated patients. But that's kind of the minutia that I'm concerned about this real, we have to go hire people, we have to institute these places, and what are we going to talk about what their work needs will be, and how are those figures arrived at if the capacity, the need is gargantuan. And I would like some more, I guess, detailed answers in regards to that. To be able to fill that, and based on realistically what can we hope to provide, and the different roles of different people, for example, the staffing of nurse practitioners or physician's assistants per physician who oversees a certain number of other providers. That would help us a lot, I think, in terms of prioritizing where we're going to spend our money, that's going to be a big outlay of money. It was specialty care, and even with primary care, we're only seeing 12 people a day. So I think that I would appreciate a little more detail about that in kind of just a nitty-gritty way. So, and that was kind of all I had to question about.
Sure, and I'll defer to Danielle and Dr. Sharma, as this is truly they're the experts here, but I would say that those numbers in general are arrived at through kind of 3 sources. So the first would be benchmarks that are nationally available that Guidehouse has access to for physician groups nationally. A second would be our experience with other safety net health systems. So we understand that the safety net is a unique population that need to be cared for in ways that are somewhat different than other populations. And a third is discussions with Central Health staff and leadership to better understand kind of how those two first components will play into the actual community here in Austin. And of course, that varies by specialty, by clinic type, by location.
Let me interrupt you. That's the thing that Ann Kitchen was saying about sort of what will be novel. And I've been a volunteer in clinics taking care of these patients and have worked in these clinics. If we're going to provide this care, I think we need to be a lot more creative rather than accept, well, this is the acceptable number of people to be seen in a day. I think that we have to be a lot more creative about that to actually deliver the care that needs to be delivered.
No, and absolutely, and I hate it that we're having this conversation right now because we are missing Dr. Shalsha, who is incredibly creative, is incredibly experienced, and has deep experience working in building out kind of new and innovative care models that both in our community and in other communities that serve the needs of the safety net population. And so I think it'll be good for us to continue having conversations with Dr. Shalsha present, who he's not our only subject matter expert. We have deep expertise from Guidehouse and other, providers that we're working with.
Community care.
Yeah, absolutely.
Okay. You did exactly what you said, less than 5 minutes. Appreciate that. This is not the last time that we will see this information. It will come back. And so if we need it depends on where we need to, have this discussion. If it's a deeper type of discussion, we just look at the committee agendas and see where we can fit it in so that we don't have an all-night meeting. Okay? All right. Thank you very much, Monica. Thank you, Guidehouse. We appreciate it. Great work. Agenda item number 6, receive and discuss updates on the 1115 Medicaid waiver, the Community Care Collaborative, and other healthcare delivery partners, programs, projects, reporting, and arrangements, including agreements with Ascension, Texas, and the University of Texas at Austin. Mike Giesland will be presenting.
Yes, thank you, members, and I'll be brief, realizing there's tornado watches out there in counties that people are going to be traveling to or through. What you've got in your packet is really just for, again, for acclimation purposes. You've seen this 4 different times. We did have a discussion about it briefly in January. We need to come back and talk to you about this pursuant to, subject to the call of the chair at the May Strategic Planning Committee meeting. But again, we want to keep this reporting matrix in front of you so you can get acclimated to the terminology. And then so that when we cover it in May Strategic Planning Committee, that sets us up for future reports as we head into the budget season from UT. And again, just wanted to bring it to your awareness, but that's it. Thank you.
Thank you, Mr. Giesland. And in essence, we're going to take that document that's in the draft of the packet and go through the detail. We're going to have people that sit down and walk us through it, give us a high level of information as to what it means and how it's addressing some of our concerns with regard to how our $35 million is being spent. Okay?
Thank you.
So that will be in our strategic planning meeting next month. All right? Subject to Dr. Benson's approval of the agenda. All right? Okay. Thank you very much, members. We are now on agenda item number 7, confirm the next regular board meeting, date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, May 24th, 2023 at 4 p.m. or immediately following the Executive Committee meeting at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. Manager Valadez.
I move that we adjourn.
And Manager Jones seconds. I have a motion for Manager Valadez, second for Manager Jones. All in favor?
Aye.
Any opposed? We are adjourned.
Thank you.
Thank you.